there's another frontline study that was recently reported, the INTORACT study. That was a phase 3b study looking at 2 combinations of therapy up front, either taking bevacizumab and combining this with temsirolimus, or bevacizumab plus interferon, the FDA-approved frontline regimen for that agent. These were done predominantly in clear cell renal cell carcinoma patients, and the results have been reported now for progression-free survival and overall survival. Brian, do you want to walk us through that study and those results?
Sure. So the genesis of this study and many combination studies was that as these single agents developed relatively simultaneously, 7 to 8 years ago, as oncologists, we like to put things together, right? We like to put drugs together. It's been the paradigm for cures in lymphoma and testicular cancer and otherwise. So we started to think about combination of VEGF and mTOR, 2 different pathways, and a lot of rationale that made sense about why we would put these drugs together. There was some very preliminary experience with the combination of bevacizumab plus temsirolimus showing high response rate, tolerability, et cetera, and a relatively large leap was then taken to study this in the phase 3 setting against bevacizumab interferon, which is also an approved regimen for kidney cancer. So again, this was a large randomized study of clear cell patients. And what it showed, unfortunately, was that there was no difference in progression-free survival at about 9 months. And the overall survival was preliminarily, but no apparent difference as well. As you get more drugs, you get more toxicity. So we just had a big discussion about balancing toxicity. That's even harder to do with 2 drugs. So there has to be a very clear advantage for combinations for them to be worth it on many fronts. And I think what we've learned in this trial, maybe just one example, is that at least with our present agents, combinations really aren't a path forward. They may be with novel agents and it needs to be explored, but of our current agents, their FDA-approved use and how they should be used is as monotherapy.
Fair enough. Anyone else thoughts on that study?
Well, I mean, I would just ask Brian the critical question, and that is that many of us, myself included, use small molecule inhibitors as our frontline treatment. But clearly, bevacizumab and interferon have high-level evidence to be used. And it's still a little unclear to me how, when and if Bev should be used in the frontline setting when compared to a small molecule, because they've really there's not been a compar's equivalent of Bev interferon to sunitinib or pazopanib. You have some thoughts about when you might use it or consider other people to use it?
Yeah, I mean, the development of that drug's been interesting in kidney cancer and different than the others. So as a single agent, that was the first data. And I think, at least for myself, I probably underestimated the activity of that drug when Jim Yang first presented that phase 2 trial, because the response rate was 10%, and that's kind of in the background noise. And I don't think we appreciated tumor shrinkage at that point like we do now. Right. So again, that regimen was developed with interferon, because again, at the time, interferon was a community standard of care. And here was a drug that seemed somewhat active, and so let's add it to our standard of care. Seemed like a good idea at the time. There's now data of Bev as monotherapy, right, from the ECOG-BEST trial, presented, not yet published, showing that, compared to some of these doublets, it's just as good from a PFS standpoint, and no question better tolerated. So if you think about risk-benefit, from a risk-benefit standpoint, you could make an argument, although without level 1 evidence, that it's the best balance of risk and benefit. Probably provides you that PFS in the 9 to 10 month range, and as monotherapy, really pretty well tolerated day to day. It is an infusion, so there's that inconvenience, but other than that. Then what happened was, all these TKIs came along, and the companies involved with those drugs were I think, more developing those drugs more aggressively in this space, whereas Bev had utility in colon cancer and brain cancer and other things. So it's kind of sort of slid into the background. It really hasn't been developed. But to answer your question, I think about it, certainly if patients have trouble getting oral medicine from a copay standpoint. I think if it's an elderly patient where I'm worried about the side effects of any of the TKIs, even pazopanib or whatever our best tolerated TKI is, I think about it. The role of interferon's a whole nother question. I think it probably adds something in terms of benefit, but it also adds a lot of toxicity. So I tend, if I'm going to use interferon, to start at low doses and get rid of it pretty quickly. And I think that's kind of sort of been the compromise for many of the investigators and many of the doctors using it.
Yeah, for me, I think the challenge with this drug has been the lack of level 1 evidence that you can use it as monotherapy. And individuals really patients do not want to take interferon. So it leaves it in this limbo. It's intravenous, plus there's a subcutaneous agent. The oral agents are certainly more convenient, and it's hard to convince ourselves that without that level 1 evidence that the monotherapy is the way to go. So it makes it just more complicated to use from a logistic perspective. There's no question it's a good drug. We had a phase 2 study in the pre-surgical setting. We found it was relatively safe. The progression-free survival was good. But it's, I think, sort of an investment from a company perspective that's left that is not one of the favored agents.
Are there subpopulations for you as well, Eric, that you'll consider this in as your treatment choice, whether it be elderly or comorbidities or other factors?
So one person that comes to mind is I have a gentleman who's paraplegic from a CVA that he had 20 or 30 years ago. It's very hard for him to deal with diarrhea. And he's been on Bevacizumab now for over a year and has really not had any issues with it whatsoever. So this is, I think, a good example of a person where this was a drug that really fit his needs.
And I think that's really a great example. I mean, when you have multiple agents across a space with efficacy, you spend a lot of time trying to tailor the agent to the patient, as opposed to just saying, I'm going to use one agent in all patients. And it means that your understanding of the toxicity profile and the quality of life issues then become predominant in thinking about how to choose an agent for a given person. And that's just a great example. Whereas if you took the book, you'd say, I'll let him deal with his GI toxicity and give him an oral agent. And then you know the information well enough to know that that's not a side effect of Bev. And you just go ahead and he's done well. It's an excellent example.
Tom, in the community, I mean, is this something people can do? Is this a coverage issue? How do you think this plays out in the referrals that you see from other clinicians and people, their ability to use the full armamentarium of treatment options that we have in the frontline space?
I think it's underutilized and under-recognized. So I think in the community oncologist perspective, they're very aware of and they are detailed by pharma reps about the oral drugs, and that's what they tend to use. So I agree with my colleagues here that I do use Bev. I usually use single agent Bev in unique situations, just what was described to you. So when I have patients referred, I tend not to see them on Bev. I'm the one who tends to recommend the Bev to them. It's almost like they don't think about it as being one of the options for them.